هنبدأ أول محاضرة بروفيسور ديمتريوس جوليوس. كان شرفنا السنة اللي فاتت بمحاضرتين أكثر من رأينا عن البوليسيستيك أوفري، وكان معانا فيزيكال هنا في إسماعيلية على البوليسيستيك أوفري والميل هايبوجوناديزم. دي ثالث محاضرة اللي معانا في الإسمة، بس دي هتبقى ريكوردد. وإحنا يعني الحقيقة برضو عشان الوقت قللنا شوية في وقت المحاضرة، لكن إن شاء الله يوم الجمعة هنعرض المحاضرات كاملة بتاعت السبع خواجات اللي معانا. هتبقى في فيرتشوال ميتنج من الساعة 7 للساعة 11 يوم الجمعة بالدسكشن، الناس اللي احنا دخلنا معاهم دسكشن. بروفيسور ديمتريوس جوليوس واحد من المتخصصين في الريبرودكتيف اندوكراينولوجي، كنا قابلناه دكتور عارف موجود في الاندو بريدج، هي من احد من الناس اللي رائعين جدا في المجال. فهنبدأ محاضرته، اتمنى ان شاء الله تستفادوا منها. يلا.
Good morning. It's a great pleasure to be with you at this Congress of the Egyptian Society of Metabolic Syndrome, accepting the kind invitation of Professor Ahmed Tag Abdallah. These are my conflict of interest. They are strictly academic. I thought that a practical way to approach our topic is to set a series of questions and try to answer and critically appraise them. So today we will discuss gestational diabetes definition, the pathophysiology behind the disease, its association with type 2 diabetes, the short and long-term complication of gestational diabetes, its follow-up, and of course, its management. So let's kick off with the definition. Gestational diabetes is glucose intolerance, that is hyperglycemia, that appears or is recognized for the first time during pregnancy. There is still a debate about the first trimester of pregnancy. Some experts believe this definition applies only to second and third trimesters, whereas others state that gestational diabetes can occur very early. In any case, a percentage of gestational diabetes is actually type 2 diabetes that was not recognized before pregnancy. Threshold does not exist. The definition of gestational diabetes is a matter of convention. The research group chose the glucose values corresponding to a 75 increase in the risk of an adverse outcome compared with the mean glucose values. So this became the International Association of Diabetes and Pregnancy Study Groups criteria and were adopted by several European societies. Therefore, if a woman fulfills this criteria, this means that she has a 75% increased risk for developing a complication. Subsequently, special care on top of standard obstetrical follow-ups seems justified. On the other hand, if the OGTT results in values that define type 2 diabetes out for pregnancy, then most probably pre-existing type 2 diabetes and not gestational diabetes is the correct diagnosis. Later on, we will discuss the thin line between gestational diabetes and type 2 diabetes. So let's continue with the pathophysiology behind gestational diabetes. This is a pregnant lady, her baby, and the placenta that enables the communication between them. Almost 50% of the nutrients that a pregnant consumes are carbohydrates. Insulin is secreted to drive glucose into the cells. As far as an embryo exists, the placenta secretes substances towards the maternal circulation. The placenta can excrete compounds either to the maternal or the embryonic circulation exclusively. These substances induce insulin resistance. The most well-studied of them is placental lactogen. So teleologically speaking, this mechanism is introduced so some nutrients can reach the embryo even in grave situations such as food restriction. The embryonic pancreas produces insulin to utilize the glucose load. This is a normal condition. It affects all pregnant women and does not result in gestational diabetes. But in 10% of pregnancies, as we discussed, additional insulin resistance exists, mainly due to two reasons. The first is genes that predispose to type 2 diabetes, whose action was not apparent until this early age. The second is suboptimal environment, and by this I mean mainly the caloric balance, so increased weight before pregnancy, gain of excessive weight during pregnancy, lack of exercise, and so on. So these additional sources of insulin resistance increase glucose concentration in the maternal circulation and drive them towards the embryo. And these are no good news, as in adults we want adequate nutrients for the embryo to have an unrestricted development. We do not want excessive nutrients that may result in macrosomia and subsequent complications. What are the complications of gestational diabetes? For many years, we used to focus only on short-term complications. This may affect the mother, particularly hypertensive disease of pregnancy, and mainly the embryo, such as macrosomia and hypoglycemia just after delivery, due to the abrupt discontinuation of glucose transport through the umbilical cord and the relative hyperinsulinemia of the embryo. But it's since the 80s that David Barker provided evidence for the fetal origin of adult disease. Let's assume that a pregnant woman lives in an environment where malnutrition exists. Genetically speaking, there is no problem with the embryonic pancreas, which could be 100% functional. Nevertheless, during the crucial period of its organogenesis, the pancreas has a suboptimal stimulation due to the suboptimal glucose load that the mother secures for the baby through the mechanism we have already discussed. Therefore, it can only produce small amounts of insulin and loses forever the ability to produce more. Initially, there may be no problem, as the neonate will unfortunately continue to live in the same environment of malnutrition. But if the circumstances are improved, he or she may develop diabetes during adulthood because of the inability to produce an adequate amount of insulin. This diabetes cannot be justified either by family history or the present body mass index, a lifestyle. It's only the fetal origin of adult disease that can interpret it. The opposite may also exist. In a state of overfeeding, the mother delivers excessive amounts of glucose towards the genetically intact baby that forces the embryonic pancreas to overwork during its organogenesis. This suboptimal in utero environment may result in pancreatic exhaustion early in adulthood. So according to the fetal origin of adult disease, suboptimal endometrial environment, in this example either malnutrition or overfeeding, may result in disease many years later during the adult life. It is of note that both malnutrition and overfeeding result in the same disease, that is diabetes. Only the optimal endometrial environment provides the highest possibility for a healthy adult life. This inverted U shape is well known in endocrinology even outside pregnancy. As an example, both acromegaly and growth hormone deficiency can result in cardiovascular disease, diabetes. Now that we have discussed all the pathophysiologic background of gestational diabetes, it's rather easy to define a follow-up strategy. Of course, a strategy of home blood glucose measurement must be applied. Usually 2 to 3 measurements a day, fasting and 1 hour postprandial are enough. Continuous glucose monitoring is used mainly for pre-existing type 1 diabetes and not gestational diabetes. Glycosylated hemoglobin is not very useful as it applies to larger time intervals, months rather than weeks. In this context, fructosamine, which reflects the mean glucose concentration during the previous 20 days, has been applied successfully. But the message here is to apply not only metabolic but obstetrical parameters. So the second and third trimester ultrasound can provide valuable information on fetal development, including body dimension, estimated fetal weight, and presence of hydramnios. This is a measurement of the head circumference and the biparietal diameter. These are non-metabolic areas, so they depend mainly on the genetic background of the fetus, for example, the parental height. The same is true for the femoral length. On the contrary, the abdominal circumference in a degree equivalent to the waist perimeter of an adult depends on the fetal's metabolic status. So it can be used to determine if a fetus is developing in an optimal way, or there is a tendency towards macrosomia, or the opposite, which is IUGR, intrauterine growth retardation. A therapeutic approach would be more aggressive if the obstetrical parameters are deteriorating despite the relatively satisfactory metabolic control, and less aggressive if the obstetrical parameters are optimal despite the suboptimal metabolic control. That brings us to the final question, the optimal therapeutic approach. Today we will discuss a pyramid-like approach that can be applied in every case of gestational diabetes, usually in that order, from the base to the top. The cornerstone is the diet, or to be more precise, the medical nutrition therapy, as the diet is equivalent to a medication. We know only a few things about diet in pregnancy. The Institute of Medicine, with this recommendation, which is already more than 10 years old, suggested the optimal weight gain during pregnancy according to the pre-pregnancy body mass index. We know that we must target towards the lower than the higher part of these reference ranges. Remember the exponential weight gain during pregnancy, which we have already discussed. For a pregnant woman to gain 11 kilos, which is optimal, given a normal pre-pregnancy body mass index, she must gain only 3 kilos until the middle of the pregnancy. We can easily agree on some basic principles of medical nutrition therapy: achievement of euglycemia, avoidance of ketosis, acquirement of optimal weight, possible contribution to fetal health, positive contribution to fetal health. The involvement of a dietitian as part of a multidisciplinary team is always a good idea. This multidisciplinary team must consist at a minimum of endocrinologists or diabetologists, obstetricians or fetal maternal specialists, midwives, dietitians, and ergophysiologists or experts in physical education. Nevertheless, many issues remain obscure. Are the reference ranges for gestational weight gain the same in different races, maternal ages, and twins or triplets? Is the total number of calories calculated according to pre-pregnancy or the current BMI? What is the optimal distribution of calories among meals? What is the optimal percentage of carbohydrate intake? The next step is physical activity. To be precise, this step always takes place together with medical nutrition therapy. According to a famous motto, exercise is medicine. Indeed, exercise can enter glucose in the cells through dedicated pathways independent of insulin. Therefore, it is a true equivalent to a drug. Appropriate physical exercise will help not only in controlling the metabolic status, but strengthening the abdominal and perineal muscles that are crucial for the delivery process. Good postures and optimal balance of the pregnant woman are additional benefits. There is no evidence that swimming is contraindicated. These are the absolute and relative contraindications for physical exercise during pregnancy. They may appear to be several, but fortunately they are rare. Most pregnant women have none of them. Of course, applying the correct physical exercise is an art by itself. To just advise the woman to exercise is naive, to say the least. Exercise must be prescribed the same way you do it for a pill. According to one regimen, you have to determine the frequency, once a day, once a week, the intensity. Keep in mind that the pregnant women may have 100 beats per minute as a baseline. The time, 50 minutes, half an hour. And of course the type of physical exercise. Have yoga, Pilates or biking the same effect and safety? Once again, our group tried in a systematic way to synthesize the evidence on exercise for normal pregnancy and pregnancy complicated by gestational diabetes. I refer you to this publication for further reading. In any case, there is a higher degree of agreement compared with the medical nutrition therapy. Target heart rate of over 150 beats per minute, a frequency of 3 to 4 times a week, and a duration of 45 minutes with appropriate breaks. If lifestyle modifications are not enough for controlling hyperglycemia, anti-diabetic medication could be the next step. Metformin is an obvious choice for Europe, whereas gliclazide or glibenclamide has been used in the United States. Metformin crosses the placenta, and there is some evidence for possible mild adverse outcomes in children exposure, if the children are exposed to it, mainly increased subcutaneous fat. Nevertheless, several randomized controlled trials and meta-analyses have proven its efficacy, although insulin addition was necessary in 50% of the cases. Two issues deteriorate the use of metformin during pregnancy. The first is its characterization as a class B medication, which is unlikely to change during the following years. Many physicians are reluctant to prescribe medication unless it's class A. The second issue is the relatively short duration of use, only some weeks from diagnosis to delivery, which make insulin, which is a class A medication, an attractive alternative. The motivation of the pregnant woman is also of concern, whereas older individuals with type 2 diabetes do not want to start an injectable agent. The typical pregnant woman will do anything to maintain her baby's health as far as it is safe. For the majority of scientific societies, insulin is the first-line medication following lifestyle modifications. The usual questions for insulin therapy apply here as well. When to start, which type will be used, how will be delivered, and what is the therapeutic target. We have already discussed that the answers to these questions depend on the combination of metabolic and obstetrical parameters applied for the follow-up. I must mention a pharmaceutical company, and this is Novo Nordisk, as it always takes the burden to conduct randomized controlled trials specifically for pregnancy for the insulins it circulates in the market. Therefore, we have evidence for the efficacy and safety of insulin detemir, a long-acting insulin analog. Deglutec is another Novo Nordisk insulin of ultra-long duration, which is approved for its use in pregnancy. In the rare cases that basal insulin is not enough for achieving the therapeutic targets, short-acting insulin could be added. The usual approach is to start with long-acting insulin, deliver at bedtime to cover fasting, that's morning hyperglycemia, and add short or ultra-short action insulin before meals as required. These insulin analogs have also proved their safety and efficacy during pregnancy. This armamentarium, if applied properly, can restore euglycemia and reduce the complication rate. In rare cases, pregnancy can ignite tremendous insulin resistance. If I recall well, in one case of gestational diabetes, we had to provide 400 units of insulin per day. So our aim for today was to discuss the pathophysiology, the diagnosis, and the treatment of gestational diabetes. I only hope to have achieved this goal. We set a series of questions and tried to answer them. In an attempt to define gestational diabetes, we discussed the International Society criteria and highlighted the rationale for its definition. Regarding pathophysiology, we discussed how pregnancy induces insulin resistance. Concerning the association between gestational diabetes and type 2 diabetes, we agreed that gestational diabetes is actually type 2 diabetes that is temporarily unmasked due to the additional insulin resistance induced by the pregnancy, and that a woman with gestational diabetes must not be abandoned between or after her pregnancies. As far as complications are concerned, we are nowadays wiser by understanding the concepts of fetal origin of adult disease and epigenetics. Regarding follow-up, we focused on the importance of applying both metabolic and obstetrical parameters. Finally, for treatment, we discussed briefly a series of approaches that, if applied properly, can restore euglycemia and reduce the complication rates. The Greek Societies for Endocrinology and Fetal Maternal Medicine have published the latest available national guidelines for both pre-existing and gestational diabetes. They can be downloaded from this link. You can have a photo of it. And finally, in a Springer book, we had the opportunity to gather experts on the field from over the world. These are the book's contents. So I must cordially thank the beautiful Ismailia. I wish to be there with you and all of you, especially Professor Abdallah, for this kind invitation. Greetings from the equally beautiful Thessaloniki. Thank you very much for your kind attention.